All right. Well, welcome everyone to our October 25th, 2024 Project Echo Dementia session. Lovely to see you all. Thank you for taking the time to be part of our community. I'm going to go ahead and share some slides here to get us started. I've got some strange things happening on the technological side here at Harborview. Does that look okay? Great. All right. All right. So again, welcome to our session. As our customary processes, we'll do some very brief opening notes and reminders. If it is your first time with us, we'd love to meet you. If you could put your information in the chat just so we can keep track of our attendees and community members, that'd be lovely. Who you are, where you practice, and what you do would be great. And then we have the great good fortune of having Dr. Lena Fine return for another in a fantastic series of talks on sleep with a focus on sleepiness and fatigue in older patients. And if my math is correct, I think this is your third time with us. But, yeah.
Something like that. Thank you for inviting me.
Oh my gosh, it's such a privilege to have you back.
Of course.
Okay, so just a few reminders. It looks like everybody is accurately named here, but having your info about your name and your clinic is always great for us, and Samuel will reach out to you if needed. Just reminders for us all to, not so much the muting, just remembering to unmute. I've done that twice today already. You'd think 5 years into it, we'd have it down, but apparently not. And then if you're able to, always great to have your video on, but understand that that may not be feasible due to location or bandwidth issues. Also, if there are multiple of you in the same location, would be great to know who's there. If you could put that in the chat as well. But that seems less common these days. Some CME information. So we are accredited through the University of Washington. If you are a University of Washington affiliate, faculty, staff, student, trainee, this is the process for you to send your email address to that phone number and texting that number, the 10085 for CME. You should get that response. I'll leave this up for a second if you want to take a picture of it. We'll come back to it at the end also. That info. And then for everyone else, we keep track of that, hence the request to have information in the chat or your name. If needed, we will certainly reach out to you. So just a reminder that we are able to provide free CME and CNE for this fantastic program. And we are part of a much larger effort here at the University of Washington to continue efforts around education. Our kind of inspiration program in a way and companion program, UW Echo Geriatrics. I know some of you also attend that. Absolutely fantastic series on the third Friday of each month. We tried to be strategic to not compete with them, but augment. So that's another great thing. The TBI Behavioral Health Echo, Psychiatry and Addictions, Telebehavioral Health Training Series. I'm also aware that the University of Washington continues to provide consultation hotlines, and we've got a fantastic psychiatry consultation line staffed by some of our prior presenters here. There's also a pain and of course the stroke phone, which is through neurology here as well. So lots of options that sometimes we forget about or don't have right at the fingertips when we need them, but we want to make sure we cover those. And then of course too, the psychiatry grand rounds archives, neurology grand rounds, neurosurgery, lots of, maybe too much information, but a lot of it. Some reminders, we do not have a formal case today, but it'd be a great opportunity to share some vignettes or some curbside kind of consults with our community. Just reminders too to make sure that we are protecting PHI. We can always go back out and edit it out, but better to do so preventatively and proactively. And just a reminder too that all of our sessions over these last 4+ years are recorded and on our website. And we continue to make some changes and use your input to help craft this program. So right now we are busy creating the agenda and the curriculum for 2025 and has some ideas about what we think would be good, but would love to hear from you. Any desires, wants, topics that we should revisit. And I don't know, Sammy, if we have a poll that we can throw up there at the moment, or let's do that just to see if there's any. We have some time today, so this is your chance to pitch what you would like to see for topics for our didactics. And I'm guessing I have to stop sharing here for you to do the poll. See what I'm seeing here. Give that a couple of seconds. You're also welcome to throw anything in the chat if there's a topic. Some of the things that we've been thinking about are revisiting the topic of screening with a focus on underrepresented and disproportionately affected individuals, right? So if you're going to use the MoCA, how might you modify it or interpret it differently based on different demographic variables? Looks like it's another way to do that. We have thought about a detailed series on the most common neuropsychiatric symptoms. So maybe a session on wandering, one on agitation, best practices around managing that. That's some answers. I'll keep sharing. Maybe we can work through this as the poll is up. And you can always include things too on your post-session surveys, or reach out to us directly too. That's another way to do this. Already mentioned we are accredited for CME. No disclosures that are relevant, and anytime there is a disclosure, there's a strict mitigation process here. Here's our lovely hub team. And here are all of you. Yeah.
You're not sharing. Sorry. You're
Oh.
not.
Oh, I got kicked out. Interesting. It shows me it's still sharing, but maybe I have to close the poll.
You're
You're
see.
good. That was my bad.
Okay.
I had it on the wrong view.
Nice try throwing me off on a Friday afternoon. Gotta try harder than that. I was born at night, but not last night. All right. Questions about practice. So again, we don't have any formal presentations, but certainly a great time to talk about your pressing clinical issues. And with that, I will turn it over to Dr. Fine, who will talk with us about sleepiness and fatigue in older patients. Now I'm going to stop sharing.
Great. Am I the only? Okay, so I will start sharing now. Thank you. What did we do? We can do this again, right? We did this. All right. Can you see? Yes, someone? Yes.
Perfect.
Yeah. Okay, good. All right. Thank you everyone for joining for my talk today. I'm honored to be invited back to speak about various neuropsychiatric, specifically sleep-related aspects. I'm a neuropsychiatrist with training in sleep medicine. And so last year, it feels like a minute ago, I spoke about sleep and, you know, bottomless topic, but I thought maybe we could talk about the dark sibling of sleep this time, and maybe talk about, of course, we will touch on sleep because what kind of talk would that otherwise be? But let's talk about kind of the dark horse, the fatigue and sleepiness that is an implied sequelae of, let's say, poor sleep or something wrong with sleep. So I'll try to break it down what we even mean by these terms. We're all intimately familiar with them, both from our patients and from our personal experiences, but sometimes we maybe take them a bit for granted. So with that, I'll start, and just unmute yourself if you'd like to interrupt me, because I'm not going to see the chat potentially. So if you can hold on, and if you have a question to the end, or just unmute and start speaking, and I will stop. I have nothing to disclose, no conflicts of interest. So where did the fatigue idea start? The fatigue idea, one of the earliest descriptions, was by an Italian physician, Angelo Mosso. Back in late 1800s, he became interested in the idea of fatiguing muscles. This was the time of industrial revolution. This was the time of pushing people to work longer in the factories. And this was also the time when the electrical measurement of muscle became more and more of an established physiological research. So he started some of the earliest topics in this area of research was the question of peripheral fatigue. Well, what does it mean to have tired muscles? So he devised various complicated machines to define the fatiguing of the muscles. As our knowledge has expanded, of course, we have moved into a much bigger question. Well, what does it mean for not just the muscle to be fatigued, but for the brain to be fatigued? And to jump 100 years or so, actually probably 120, more like it, we now have a lot more to define about the idea of the fatigue. I'm going to take a pause from defining the fatigue and sort of talk about, well, where do we find this notion of fatigue? Where in the brain or in the body is it actually located? And there are many different theories the way we want to think about it. Sometimes we want to think about it in terms of actual localized regions. Insula, for example, is credited with recognition of salient events. Acting on an event may be linked to this particular part of the brain. Striatum may be linked to motivation. So in patients with Parkinson's, apathy and inability to act on the action may be translated into feeling fatigued because of this decreased motivation to take an action. However, another way to think about fatigue is to think about what researchers think of as edges or connections between different parts. So connection between striatum and prefrontal cortex. How do you motivate and then actually execute? How do you modulate a particular action? So this is where the notion of not just feeling fatigue that you can measure in the muscle, but how do we experience? What does it mean to feel tired? It has been postulated that perception of fatigue may be connected to these edges, these relationship between different parts of the brain. And then, of course, we can't get anywhere without large-scale networks. It's a very in vogue right now with AI and large language models. Well, large language networks was kind of the origin of that, and that's another way to think about how fatigue is regulated in the brain and how do we process the information. So information processing efficiency. And then is there a more novel theory called posterior to anterior shift, meaning that it is healthy, and I'm going to take you to this confusing graph in a second in this circle, but maybe what's happening is that as the brain ages, there is a posterior to anterior shift, meaning the frontal regions take a lot more of neural compensation to monitor the brain and be able to act when the body becomes tired. So that's the frameworks, the nodes, the connections, the large networks, and the shift from the posterior to anterior, from the posterior to anterior modulation to understand what it feels like to be tired with age. And of course, looking at the circle, we have, questions that one must be thinking about. What does it mean to feel fatigue? How long does it last? Persistency. How prevalent is it in one's life? Is it interfering with one's ability to function? Is it interfering with one's ability to maintain relationship and have hobbies? In elderly, one of the big issues is that if one feels fatigued and gets physically withdrawn, that drives dependency on others, and dependency on others means increase in disability, loss of independence. So the idea of how valent fatigue may actually be connected to the psychosocial situation of the patient, and of course, intensity. Is it how intense is the experience, and where is it found? Is it in the body? Is it in the mind? Is it how do we experience it? So without dwelling too much on the theoretical models, I want to be sort of thinking of fatigue in terms of what it means. Well, I'm not going to take you too much through this, but just to think about the fact that what's normal reaction to fatigue and what is not normal. So, a typical aging brain can experience fatigue. What they mean here by biomarkers is a variety of, what I've talked about. How well do the different, it's not an actual sort of biomarker in sort of you can measure necessarily, but the biomarker of which part of the brain is engaged, which neuroendocrine axis is involved. That sort of biomarker is used here in a broad sense, that if a typical brain experiences fatigue, how well can it resist these biomarkers and remain resilient versus how much of that will lead to vulnerable pathological aging brain. Again, this is theoretical fatigue framework, but it's to lay the groundwork so that we, the clinicians, have at least some vocabulary as we think about the thing that seems to be so plainly obvious and yet is actually quite complicated. Now, this I put in just an example, not because I want you to focus on the specific little blue spaces in the brain, but the fact that I'm sorry, it came out a little small, that fatigue and sleep actually don't localize to the same place. Sleepiness and fatigue are not synonymous. It is true that fatigued individuals might have worse sleep, whether it is because they're so fatigued that they weren't able to exercise, so their sleep quality is worse, or maybe their insulin regulation is worse. But we know that fatigue and sleep are not synonymous. And that's sort of indicated here in the turquoise and blue being different spots where sleep and fatigue are controlled. But I don't want you to hang up on these maps because, again, it's not just about nodes, it's about connections between these networks. So we as neurologists, as psychiatrists, often trying to understand, what does it mean that the person says they're fatigued? What does it mean to have central fatigue when the person says, I am tired? So one way to think about it, is it the failure to initiate and sustain attentional tasks that involve just cognition or physical activities that may require self-motivation? Back to striatum, right? That's one way to define it. And what about the tasks of cognitive vigilance, places of effort where you need to really focus rather than those performed over? So is the fatigue something you do that's really tough? You have to get in and solve a problem versus doing something that may be a little easier, but you have to do it again and again and again. So is it something that's done with effort, or is it something that's done over a prolonged period of time? Patients may report fatigue and low performance, but they might actually feel tired but perform well. So there's a very important subjective experience that we have to honor, while maybe objectively, let's say that muscle contraction hasn't changed. And of course, ultimately, how much does it contribute to the individual's quality of life? How much can they function and in what they consider a fulfilling life, given this central fatigue? So this subjective experience is maybe, we can measure it all we want, but in the end, what matters is what the patient tells us. So this subjective feeling of lacking energy versus objective measured muscular or cardiovascular performance. What patient says versus what they actually mean. Because it's so universal to feel tired here and there, we might assume we get it when someone says that they're tired. But I think it's important to understand, just based on what I said earlier, that it may mean different things to different people. An important distinction, maybe it is self-evident, but cognitive fatigue is not cognitive impairment. And most importantly, it's embedded in the personal experience. And there we're back. I think it's never too much to reinforce this idea. Does it happen when you are in a sustained mental effort while you're doing it? Or is it after you're feeling okay doing it, but afterwards you're wiped out? Does it mean that it didn't, you're not able to get the level of alertness and vigilance that is required for the task at hand? And how does it impact your feeling of being able to operate cognitively at work, in the home arena, whatever arena is appropriate to a person's life, and how does it affect their everyday life? So that's the definitions, being able to not just say fatigued, but split it. Is it physical? Is it cognitive? Is it during the effort or is it after effort? Is it not even being able to build up the effort? And then look, I'm really being very careful here to say it is not the same as feeling sleepy. They are cousins, but they're not the same. So what may be some of the causes we need to be thinking about? Again, this could be physiological gray matter atrophy, especially in the hippocampal area. There is some evidence to show that hypometabolism in the prefrontal premotor cortices may correlate to fatigue. There is certainly a connection to basal ganglia. A lot of neurodegeneration, we see a lot of fatigue. So connection to the limbic system, being cortically driven voluntary activities, just not being able to be up to it. Apathy maybe is another synonym we sometimes use. And, we cannot, obviously, we'll talk about strategies that we use with patients to try to help them when this sort of atrophy, this sort of a phenomenon is happening physiologically. But where we are, really can come into the into the arena and really make a difference is trying to understand and eliminate secondary causes of fatigue. So I'll talk a little bit about, sleep apnea, restless leg syndrome, insomnia, nocturia. I don't talk about nocturia because I don't know a lot about how to control nocturia other than several medications we all use, but does it really interrupt sleep? Absolutely. So, not forgetting the small things. So sleep related, mood disorders, depression, anxiety. Let me come back to that. The sort of medications, we prescribe medications that may cause fatigue. Simple, easy vitamin deficiencies, anemia, I put it as a separate one. It's sort of, I always focus on anemia and the sort of young women who have heavy menstrual cycles, but anemia can be fairly common in older individuals as well. Autoimmune and endocrine disorders, deconditioning and diet. So keeping this as a running in the background, is there anything that the patient is telling me that I can change? And because we can do a lot in the secondary causes domain. Well, how do we measure? There's so many different, I was going to put a lot of different questionnaires to use, but I thought, let's give NIH the credit. NIH spent something like $80 million on this PROMIS, on the range of PROMIS forms. And I think they've done a really good job. They've done it in several different conditions. So there are many different questionnaires, if anyone says one more, please use one more questionnaire with your patients. So my goodness, I'm gonna roll my eyes, please no more. But this may be a nice thing to be aware of, that this NIH effort of patient-reported outcomes is a short, as you can see, questionnaire that might help gauge, especially visit-to-visit, individuals' fatigue. So PROMIS is domain-focused, not disease-focused. What that means is that domain it's exactly what we want to understand in our patients. It's a feeling, a function, or a perception that we really want to measure. So in a way, we are trying to get at that measurement of a subjective experience that we can then track and as we attempt various treatment modalities. So let's talk a little bit about sleep and fatigue. As I mentioned before, they're not the same, but they're close enough to think of them in the same context. Fatigue does correlate with worse sleep quality. And what is interesting, though, people do get a little bit more sleepy as they get older. They don't necessarily need to get more tired. Some of the sleepiness may be related to the phenomenon that we see on polysomnograms of older people, is that sleep gets a bit more fragmented, meaning it gets choppier. We all lose deep delta sleep as we get older. And that may also contribute to sleep being choppier. It's possible that that's what's contributing to sleepiness, but sleepiness is not synonymous with fatigue, and fatigue is not automatic later in life. The interesting thing about fatigue, and again, might be self-evident, sleep serves a very important homeostatic role. We need sleep in order to function better, and fatigue, of course, does not serve that role. And let's talk about a little bit about, we know that sleep plays a role into sleepiness. It plays a role a little bit into feeling tired during the day, or a lot. So what are some of the things again, we talked about secondary causes. Let's keep in mind, what are the secondary causes of fatigue? What are some of the problems with sleep? Just the checklist in the back of your mind. Obstructive sleep apnea, central apnea rarely, but obstructive. Restless leg syndrome. I think by the time you're meeting your patients, they've hopefully been diagnosed, but you'd be surprised. And also restless legs can come with certain medications. Pain, of course, hormonal changes, and anxiety, because of anxiety being the handmaiden of insomnia, of course, something I've talked about before, but big one. It's kind of it's exhausting to be anxious, just really, really fatiguing. And then medications and substances. So I mentioned in the secondary causes of fatigue, mood disorders, major depressive disorder. And what exactly was it mean, mood disorder contributing to fatigue? Well, if you have depression, you will have certain degree of lower motivation, which will prevent you from doing things that will might bust the fatigue to begin with. You want exercise, you want to reach out for friends. So it's a self-perpetuating cycle, sort of, to understand. Again, maybe self-evident, but how exactly, which symptoms of depression, these are the symptoms that may contribute to fatigue. Sleep disruption, insomnia, as well as hypersomnia, interestingly, happens in depression. Atypical depression can happen with hypersomnia. So sleep disruption in itself can contribute. And it's helpful to have scales. PHQ-2, a lot of clinics have adopted, and you're probably using PHQ-2 sort of to screen patients. And then the longer PHQ-9, I mentioned, pay attention to question 9, because that's a question on suicidal ideations. And it can be exacerbated. Low mood can be exacerbated by medications, which I will come back to in a moment. And antidepressants can be sedating. So it's a bind to give someone antidepressant, but I always sort of, it's interesting, each patient will respond differently. Some people can only take certain SSRIs only in the morning, and others only at night. So trust their experience and shift it. Maybe have them take it at night, maybe have them take it in the morning, depending on their experience. There's no wrong way to do it, with exception of some of the antidepressants like bupropion. Fluoxetine, I have had people who want to take it at night, but usually conventional wisdom is that fluoxetine, SSRI, Prozac, is more of an activating SSRI. Bupropion, Wellbutrin, obviously has no serotonin, it's all dopamine, norepinephrine, is more activating. So, this is an exception to the potential sedation of antidepressants. This is really important. Antidepressants are not effective at treating fatigue in neurodegenerative disorder if there is no coexisting depression. It is very, it's an interesting idea. It's alluring to say, well, we know that dopamine and norepinephrine are energy boosters. This patient has the neurodegenerative disorder. Why don't we give them a little more dopamine? Why don't we give them a little more norepinephrine? But it has been shown that if there is no, mood disorder, it is better to avoid using alerting antidepressants. Generalized anxiety disorder, of course, causes persistent activation and affects fatigue indirectly, both directly by making the person exhausted with their ruminations and racing thoughts, but also indirectly by triggering insomnia. GAT7 is one way to monitor for it. And obviously, from perspective of fatigue, using a maintenance medications like SSRIs and SNRIs is better than using benzodiazepines, especially in the older population. Sometimes it's necessary to use a benzo, but ideally not. So what are some of the medications that can exacerbate fatigue, even exacerbate depression? Beta blockers, I mean, the list goes on and on. I just chose a couple that are very common that we all prescribe. Beta blockers can be wonderful even for, something like propranolol for anxiety, but they're fatiguing. They can make people tired. Muscle relaxants, pain medication, gabapentin, wonderful medicine. We all appreciate the power of gabapentin, but gabapentin can make people tired, especially people who may be more vulnerable. So obviously muscle relaxants or, if a person needs to be on tizanidine or baclofen, those are very, very sedating. So keeping in mind as you're looking through the patient's medication list, benzos, obviously. Some SSRIs, as I said, can be sedating, so it is worth playing with the timing. Steroids, interestingly, can be very mania-inducing and cause insomnia, but also in some patients can cause fatigue. So it works both ways, both directly, but also indirectly by disrupting sleep and thus disrupting the person's level of alertness. Alcohol chops up sleep like a massive salad. It really, people say it helps me fall asleep. Very true. For many people, it helps them fall asleep. But in the end, the quality of the sleep is terrible because the sleep continuity is affected, even if they have complete amnesia of that experience. Cannabis, has affected, a lot of people use it for sleep now, the gummies, CBD gummies. Very hard to find a pure CBD product apart from apart from the anti-seizure Epidiolex. It's very hard to find a pure CBD. So it certainly affects motivation and leads to apathy, and that indirectly can affect energy levels. And, these are wonderful supplements, ashwagandha, magnesium. I always remind people that they should not be taken in the morning, even if you're anxious, because they may affect your energy level. So keeping in mind that the good supplements can, taken at the wrong time, might affect the person's fatigue levels. We can never have a sleep lecture or even a fatigue lecture without just honoring the sleep apnea. I will breeze through it, I promise. Just remember sleep apnea, gasping, waking up in panic, fragmented sleep. You would probably think it's an insomnia, but maybe it is sleep apnea, even in a thin person where the tongue falls back and obstructs the airway. Morning headaches, especially in women, presentation of sleep apnea doesn't have to be snoring and gasping. It can come with morning headaches. So it's important not to miss that, especially you have someone who is a migraineur, so you just chalk it up to the migraine, but it could be sleep apnea. Obesity is a risk factor. And now that people don't need to come into the lab, there's a lot of home sleep testing that is done everywhere. So people who are sort of feel it's a big hassle, it does not need to be. So one way to convince the person. This is a scale to easily, to you referring patient to a provider, look, you can just need to have 3 of this. If someone snores, they're tired, and they have high blood pressure, that's already a trigger for getting a home sleep test. And now, by the way, as you know, Apple Watch, the latest iteration of the Apple Watch, is going to start recording sleep apnea. We're all breathless in the sleep world because I don't know if that means we're going to have lots of people coming in and saying, cure me, I have sleep apnea, but you will start seeing people who will come in and say, my Apple Watch said I have sleep apnea. Very exciting to see what will happen, but I think it's better to, make people more aware and over-diagnose it than under. Restless leg syndrome, the easiest and hardest diagnosis in the world. Urge to move the legs, irresistible. It happens worse when the person is finally sitting there watching television or whatever Netflix show. it doesn't have to be lying down, and all of a sudden they have this unpleasant feeling. And it helps if you get up, if you stretch a little bit, and once you stop, it starts all over again. It really has a very strong evening correlation. It can happen other times, but it really is classically evening or nighttime. And people don't just describe restlessness. It can feel like deep ache. It can feel like my legs are crawling. It feels like itchy under the skin. So all of those restless legs are easily diagnosed, but also easily missed. So I encourage you to keep that in mind. Just a reminder for restless legs, we really want someone's ferritin to be high. So you have a patient with anemia, they may develop restless legs. Nicotine, caffeine, alcohol, as well as antidepressants can cause restless legs. So keeping in mind that those can exacerbate. Antihistamine, someone takes their Unisom to go to sleep. That could be a very kind of a red flag that this is worsening restless legs. And things like Reglan and Compazine can cause restless legs. As I mentioned, SSRIs. The treatment, I know that I'm going through this quickly, but dopamine agonists have always been the stay. Our actually treatment paradigms are changing. Stay tuned. American Academy of Neurology is about to release a new guideline, and I think the big drug, the winner, is going to be Lyrica. Pregabalin is being used more and more for treatment of restless legs. Lots of side effects. Lots of side effects with weight gain, fogginess, fatigue, but something to just keep in mind for what's, the old is new again. Now, what do we use pharmacologically for treatment of fatigue? Modafinil, armodafinil can be helpful. Stimulants, especially, I'm not a fan of amphetamines because of increase in anxiety, heart rate, but methylphenidates, especially shorter acting, can be helpful in patients with fatigue. Activating antidepressants, if relevant, bupropion, fluoxetine, escitalopram, and not to miss things like B12. Now, B12 is great for people who are a bit low. People who are well on their way to high B12, more B12 is not going to be helpful, but checking it is, I know that it's a reflex for most of you, but just a reminder that it's important to have it there. And then iron deficiency, checking ferritin. However, ferritin is an acute phase reactant. So some people, have rheumatoid arthritis, their ferritin might be through the roof. It's helpful to look at the percent saturation because that's a stable number. And you want it to be closer to 40% rather than lower range. So just keep in mind that ferritin may or may not be a helpful point. I put vitamin D, but, I wouldn't overvalue it, but, it's Seattle. So yes, for those of you who are in the Pacific Northwest. I wanted to mention that this is a fairly new paper that came out with effect of nutrients and phytonutrients and supplements for cognitive function. And lots of a list, if you're interested, you can read the paper, but from the perspective of energy and sleep, rhodiola rosea, I like this supplement, although in this particular paper, they really looked at the studies. There are not a lot of studies like with supplements, but all supplements, this was done mostly in young women, and I think medical students, but rhodiola rosea is a supplement, is an herb that grows in northern latitudes and has been somewhat helpful in boosting people's energy levels. So if you want to use something natural rather than pharmacological, you may consider rhodiola. And I was also amused by tart cherries. Tart cherries have a lot of melatonin, allegedly. I mean, you're really going to have to drink 4 gallons of tart cherry juice if you really wanted to get some melatonin. But I know, but good luck, because it can also cause diarrhea. So when people ask me, well, should I do cherry juice? I think that's a very delicious thing to drink. I don't think it should be used as a melatonin derivative. I think it's a lovely thing, probably helpful, especially if people have constipation, but I wouldn't overvalue tart cherry juice as such. And, finally, be here for, we talked about medications, about supplements, behaviorally, I think that one of the ways research is going, trying to find a rewarding task that either rewarding to the person in the flow or rewarding because it provides them a social connection, so group exercises, or rewarding in one way or another to themselves is the direction in which a lot of behavioral fatigue management is heading in. And we can maybe, if you have questions, you can ask me more later. Of course, aerobic exercise more than resistance improves fatigue. Both are highly valuable, but that the data show points in that direction. And maybe light therapy. I mean, I think we all love light. So I think that there is certainly really great work on fatigue and light therapy in people who are recovering, for example, on chemotherapy, a little bit less robust in the area of aging. But I think it's a wonderful modality not to be forgotten, and certainly beats in terms of side effects many other things that we have to offer the patients. And with that, thank you for your attention. I appreciate it. And, I have a couple of minutes before my patient if anyone has questions.
Fine, thank you so much. That, as always, absolutely outstanding, a tremendous amount of relevant information and a very cogent and cohesive presentation. Questions, comments? I have a couple as people are thinking about them. I'm curious to hear a little bit more about home sleep studies, what you think about those in terms of,
Hopefully no one has now become so fatigued that I've lulled them into the state of contentment. Home sleep testing is great. It is about 85% sensitive. So there's definitely cases where you will miss the edges. And so as a provider, I think you should be entitled to skepticism. If the patient says to you, I have this, they get a home sleep test and they come back and they say, my test is normal. And their partner says, but I don't understand. They are snoring or they're flinging their arms or whatever they're doing. You should then send them back. And usually the sleep docs usually already do that. So it's pretty good. It's really pretty good most of the time. But if there is still doubt, that those people can then be sent for an in-lab test. But then there's going to be also people where even you feel it's a soft call. Yeah, I don't know. I don't think so. In those cases, often home sleep test is enough. And you say, you know what? Okay, we don't need to bark up that tree anymore. So that's what I think about home sleep testing.
Excellent. Okay. Dr. Hammond.
Hi, thank you. I appreciate the information. I'm wondering if you wouldn't mind just taking a moment to sort of connect the dots between dementia and sleep disturbance. I understand that people with neurodegenerative conditions have worsening sleep disturbance and therefore fatigue, right? So it's part of the neurodegeneration. Is it also, and so I guess my question is, to what extent is it useful to try to look for that and pull it out as a separate diagnosis? And to what level should we think about treatment differently in a cognitively impaired population versus a general population?
I understand your question, and I think that's a very important distinction to understand. But I think that understanding that we know that sleepiness is worse in patients with neurodegeneration, that should be, I don't want to say diagnosis of exclusion, but that should be the final destination point. My belief is that because we're aware of it as providers, we sort of become, well, this is part of the picture. And it's good to set expectations, because we also know that it damages, certain damage to the suprachiasmatic nucleus with the loss of dopamine. We know there's going to be a circadian shift. We know there's going to be a breakup in the pattern, and there's a way to work with it. But I think one should start by ruling out these other things that I talked about, because that I believe that otherwise sort of breeds complacency with us saying, well, this is part of the picture. So my belief is you first look for things we can change. And then once we have exhausted all of that, we may say, okay, at this point, we have checked all the boxes. Let's now look at your circadian rhythm and tighten it if we can. Now let's maybe start looking at modafinil. because we've tried everything else. So I think what I'm saying is I think there's a lot of value to first figuring out other possible reasons for the trouble, cleaning that up, ruling it out, treating it then, and when you're no longer left with nothing, you're against the wall with a neurodegenerative disease, then you say, we will now symptom manage you. I hope that.
Thank you.
Dr. Riley.
Yeah, I think kind of along those lines, when we have somebody with mild to moderate stage dementia and we learn they have sleep apnea, I think it's always a conversation with patients and families, how much do we say, really try to keep it on, what alternatives, how do you work with people with cognitive impairment to treat newly diagnosed sleep apnea?
It's very difficult in the more severe cases. You're absolutely correct, especially when you've got apraxia and you have someone who doesn't, the insight into why they need to do this becomes quite a nightmare. Why do I have now? I'm already having horrid sleep. Now I have to have a stuff on my face. So I think it depends on the severity of the underlying dementia. Frankly, what I think what we underestimate is sort of the buy-in from the patient. So I guess what I usually do is, I mean, if there's a severe apraxia, sometimes we just can't do anything. So sometimes we have other ways we can do positional. I can have someone sleep on their side, or I can take them to the dentist if they can afford an oral appliance. But often what we do is desensitization. So this is where we use something like, listen, I am not telling you to use your CPAP at night, but can we use it? Are you watching TV for 3 hours at night? Great. This is where we're going to have you use it. So what we do is behavioral accommodation to the treatment that we really want. It doesn't always work, but if if I say, forget about the night, so the buy-in comes from the behavioral adjustment for the patient. So I don't know if I'm answering. So in a very severe case, it may not be possible, but in a less severe case, we might acclimate the patient to the treatment to the degree where they can start using it at night.
I'm curious what you tell patients, in terms of what to expect and when to expect it in terms of potential cognitive improvements with CPAP treatment. Yeah.
With sleep apnea, oh, very good and very challenging topic. It's look at the data. We say 3 to 6 months, but to be fair, the data in CPAP for people who are already demonstrating cognitive impairment, a lot of that is not being reversed by CPAP. So what you're really setting the expectation is actually not on cognitive performance, but on the quality of day-to-day life. So the patients, say, well, my memory is not better, or the spouse says they're not remembering better. What we're trying to do is we're trying to keep them awake the whole day so that they are actually able to sleep through the night and not wake up. So I think the expectation is like, okay, well, let's see how your memory is in 3 to 6 months, but actually, what we really want to see is what is your day-to-day quality of life? How are you able to stay awake and stop napping every 3 hours and then sleep at night? So it's a question. You can look at memory, but that is actually not the emphasis of CPAP treatment in this population.
I want to be respectful of your time if you are in clinic.
Sorry, I actually have a patient to see. I thank you very much for inviting me. I hope this is helpful, and really glad that there is a platform and arena where you discuss relevant topics to this complex series of conditions.
Thank you so much for being a part of it.
Thank you. Bye.
Bye. Right. Well, we don't have a formal case, but I'm looking at some familiar names on here who I know are involved in work with sleep, and this is a great time to discuss any related or other clinical issues. Just open the floor. Or maybe everybody has all of their clinical issues all figured out and everything is solved.
I'll ask a question.
Thank you.
I'm a geriatric nurse practitioner. I see patients who are on all kinds of meds for sleep. And I'm curious for the group, like right now, we're onboarding someone who's on Benadryl every night. She's 90. I think it's pretty habitual that she's taking this. And of course, I'm going to try to maybe taper her off that and onto something else. But I just am curious for the group, like what your best methods are for first trying certain things and how you relay that to a patient who's not so keen on it.
Oh, what a fantastic and relevant and probably ubiquitous to degrees question. And I know our hub team are jumping at the chance to ask questions and comment about that. But I'm curious, other community members, are there experts out there? What do y'all do?
Maybe I'll just say one of the things that I think is really hard is, first of all, if somebody's been doing something and they've gotten to 90, like there's a certain level at which, well, I mean, we have to have a little humility, I think, I think it's important to bring humility to the conversation. Like, I've been doing this, I'm 90, I'm right. And I can say, no, you're not. And they can say, what do you, I mean, I just think we have to come from a place of recognizing that all the evidence says you're wrong, patient, and yet like your lived experience is vast. So I just think it's important to bring that in as you talk about negotiating a plan for trying a wean. Just sort of give them some credit for what they know about themselves and their body, despite what I know about science. I think the other thing that, and I would love to hear others' input on this, but to this question is like, part of the issue that I'm up against with sleep is the subjective experience of being poorly rested, which is like legit. Is that worse or better than the experience of feeling fully rested because you took a dangerous medicine? Right? Because in some ways you're asking people to make that trade. You're asking them to think, I feel tired. I feel worse. I felt better when I took my Benadryl. But like, I'm saying, sorry, but that it's less safe. So I just offer those as dilemmas that I have faced.
I very much appreciate those points, but my inner social worker also has to ask about the concept of motivational interviewing, really kind of coming to the patient to find out, how's this working for you? What are you getting out of it? And then applying that humility in moving forward. I'm also a strong believer, if it ain't broke, don't fix it. And so if this has been working for, how bad is the risk? If it's amitriptyline, maybe it's a little higher, kind of going down that list of risks and benefits. But I like that, Carol, about approaching it with humility and respecting the lived experience.
I also agree with that. Because this patient has been doing this as long as she's been doing it, and with her age, I know Benadryl sounds scary, but if she's been doing it this long, and she made it through to this point, I think it would be a good thing to have her and the family or whoever the main caregiver is. I will approach it in a way that we can, the provider, family, patient come together, talk about it, see what the risk is, see what has been happening, and then evaluate if any of the problem or if there's anything at all that's been happening as a result of her taking the Benadryl that maybe they haven't even thought about it. Just kind of help to tease it out to see if it's not much problem. I honestly think, in my opinion, I will give it time while she is being enrolled into care right now, and then do assess the patient as we go and see, have the staff or whoever the main caregiver is document and report from the patient what is going on and go from there. But I wouldn't really jump into changing anything as well.
So that's a really good point in terms of building some rapport with her before you start, poking at things that she might not like. Other thoughts?
Hi, this is Anne, PA with Peace Health in Bellingham, and I do behavioral health consults here. And I found that a lot of times it seems like people just aren't aware. Like they've been doing, kind of like some previous people said, they've been doing the same thing for many decades, and they may not even know that there's a risk. So yeah, I feel like I've actually had pretty good success getting people tapered off Benadryl once they know why it's not, good for them to be taking it every night. And if, they want to keep taking it and they feel like it's helpful and they're not complaining of sleep trouble or restless legs or cognitive concerns, then that's kind of a risk benefit discussion with them and maybe they just continue.
Points? Right, it's over the counter, it must be safe. Carol, I'm curious, I love the idea of approaching pretty much everything with humility, but especially a conversation like this. And I'm wondering how what would you say? How would you do that? If you're having a conversation with this patient about risks, the possibility of changing something.
Well, I agree with Greg that, the motivational interviewing idea is right. If you're hoping to make a behavior change, you have to understand the behavior and what their motivation is. I often use the phrase like, I'm worried. I just use that a lot with people because it's real. I have a reason why I'm worried and here's why I'm worried. Like it's true. And so I try to use that as a way to explain because it allies me with the patient. I'm worried about you. This is why I'm worried. So I often will use that as an entryway into exploring a place where we may have a disagreement. Now, I agree with, I'm sorry, I forgot your name, the person from Bellingham. Sometimes it's just they don't know. So like, of course, that would be amazing. Like, let me help you understand. But if they do know and we're at disagreement, I'll often kind of lean on this is my genuine expression of care for you. It is based on like, if I'm not doing my job, I'll sometimes also say like, if I don't tell you what I think is concerning here and what could happen, I'm not doing my job. Like my job is to help you and think about what could happen. I've been doing this a while and like, these are the things I'm worried about.
I think sometimes time helps too. Like I think we've had some patients in our program who, we've kind of given them this information the first time and then they're not interested in making a change and they go away and then they come back 6 months later with the same concerns and they're much more receptive the second time. So I think that can be helpful as well.
I appreciated the earlier comments about building rapport. As a hospice doc, our admit nurses find deprescribing very difficult because it's the first time they're meeting the patient and the patient feels like they're taking something of value away. Carol, I really like that language you used on why you express it and how to express it. But 2 or 3 visits in with their RN case managers, they're much more willing to start deprescribing because now I've got this nurse who I've developed a relationship and I understand that they are here with my best interests at heart. And I may be more open to discontinuing the atorvastatin and the other medicines that maybe you don't need when you're in hospice.
Yeah, I have the same approach to deprescribing specialists, which I also do for people in primary care. It's, same thing. You can't walk in the door. You're seeing 5 specialists like, that was appropriate 15 years ago, but you don't need to spend all your resources running around anymore. But I can't say that right at the start because that just feels like you've given up, whatever. There's all kinds of ways that lands poorly. So I agree with you. Over time, we can have a lot more traction if you keep showing up for people. Longitudinal healing relationship. Turns out it matters.
Janine, what do you think? Did that remotely come close to answering some
Oh,
questions?
yeah, thank you. Definitely. I'm gonna be seeing this person next week, and I'm not gonna try to change it, but I am gonna explore sort of why she likes it, if there's been any side effects for her. This is great. Thank you. My own mother, who she knows I talk about her in clinical forums, she's on Ambien. And she has a relationship with her internist where she gets it refilled on a regular basis. And she's like, well, he doesn't want me to not sleep well, so he's going to keep giving this to me. And so far, no adverse outcomes on that, but it worries me nonetheless.
It's tougher to have medical authority when she changed your diapers.
True. And she's 91 and doing okay. So there's that.
Yeah, I love, and I don't know if everybody here has, background or access to some training in motivational interviewing and motivational enhancement, but it is such a powerful tool in terms of that. What do you like about using Benadryl or Ambien, or what do you think about drinking? And then to go through, Carol, as you said, like, here's why I'm concerned, and now that you know why I would want you to do something like this, or your family, why would you want it? Maybe you don't, right? Then we got to go from there. But that's having that kind of, it feels very freeing in some way, but. I'm curious too, and I was hoping to ask Dr. Fine about this, but we've got other experts on the line here. Melatonin. I keep hearing different things about when people should take it. I don't know what people recommend, what they tell their patients who are trying melatonin. The data, the literature is a little bit varied in terms of the recommendations there. They can't tell, but I'm looking at Nancy and Kimmy mostly right now too.
I'm happy to share what I recommend, understanding that that's, one perspective, and informed by the wisdom of Dr. Lena Fine, dear colleague. And people, and I think that she responded to this question really well in one of her prior talks. And so I would ask people to consider looking at that. But so we know that as we get older and as we have cognitive issues and dementia, our circadian clock is affected. And so it's harder to make that transition. And so melatonin might help shift that circadian rhythm a bit. Also, getting light in the morning can help. But so starting with, to answer your question regarding melatonin, a low dose, 1 to 3 milligrams, typically don't go above 3, and taking it a couple hours before bed because it takes a while to kick in. So if somebody wants to try melatonin and they're having a hard time falling asleep, as I say, starting with a low dose and taking it a couple hours before bed is typically what we try. And I'm curious from the community, it's not rare that when you're looking at somebody's medication list, they're already on 15 milligrams of melatonin, which I'm not sure there's any data that that's helpful. So again, shared decision making. They're in the driver's seat of their own health and well-being, absolutely. And I'm concerned as your doctor that this is too high a dose for you. And what are your thoughts about? Do you think it's helpful? And might we consider? I don't think it's that helpful for mid-cycle awakening. And cognitive behavioral therapy for insomnia, which I know isn't melatonin, but is a tremendous support for insomnia is something we could bring into this discussion. And then another thought, which is kind of tangentially connected before we, is, cognitive fatigue and that hyperstim that people can get throughout the day, and helping patients and families to calibrate that for patients as their cognitive capacity is diminishing with their dementia. So it's not melatonin per se, but it's like thinking about cognitive load over time, because if you're amped up, not just with technology and violence, but also like with hyperstimulation, it's very hard as a result, and may not be evident to the family or the person, of course, who's trying to fall asleep. And so in the office, we'll often talk about that as well. It's a long answer, but that's kind of
it's perfect. I recalled her talk before saying 2 to 3 hours, no more than 1 to 3 milligrams, and then you got to give it a fair shake, right? You don't just try it for 1 or 2 nights.
right.
But the bigger picture of, how are you structuring your day? How are you calibrating your activities, the timing of those activities? That's all super important, just to first step for that. It feels like, and I don't know about others, but it feels like it's uncommon not to see somebody who is taking varying amounts of melatonin, like right as they're going to bed, or has heard, oh no, it's a half hour. Or, it feels almost pervasive that people take it. Got a few minutes. Janine, go for it.
Yeah, I was just commenting on the melatonin idea because I think we asked our gero psychiatrist what his recommendation was, and there are different research studies out there, and I think there are some that say more is not better, like higher doses are actually worse for sleep and maybe make people groggy in the morning. And I don't know if it's similar to mirtazapine, like a little is good, but maybe a lot is not. But that's just one idea I had. And also just going to adult family homes, I wanted to comment, like, I don't think I've ever walked into an adult family home. I do house calls where the TVs are not blaring. There's so much noise and people are used to it. They just start talking. They don't even have really the awareness, like there's another thing going on, that maybe the TV doesn't belong on or the volume at max. So I think they're just living in that state so much of the day.
Right, so some stimulus control. And Kelly, I saw that you unmuted, but we can't hear you. Volume up, maybe? No.
Oh,
Oh, we are.
okay, sorry. Hi, everyone. I'm Kelly. I'm a general neurologist. I just wanted to know, like with melatonin, we also use it for REM sleep behavior disorder for like alpha-synucleinopathies and Parkinson's. And we use much higher dosages. So we start at, the 3 range, and then I tell people to increase by 3 until they're up to 12 or 15. So Nancy, that might have been one of my patients you saw, because sometimes I recommend a higher dosage for the REM sleep behavior disorder. And then in my reading, I don't know why this is it. I was trying to look for my source, but giving melatonin really close to bedtime, like 15 to 30 minutes, was a thought because the effects wear off. So it'll be interesting to look at that again, what the research is for a few hours versus the 15-minute mark. Because my understanding was that the sooner you give it to bedtime, the better off it works. Now, I don't know if that's outdated or if it's newer, but just to know, like, and it doesn't work that well for REM sleep behavior disorder. I don't know what works for REM sleep behavior disorder, if anyone has any suggestions on that either, but sometimes that's why we use that higher dose of melatonin, or if you see it in my patients, that's what I'm trying to help with.
Yeah, that's super interesting. And Kelly, if you have a reference for that, we would love to share that with our community.
I was looking, I know I found the dosage in the continuum for a dose of 3 to 12 milligrams for REM sleep behavior disorder. But I'll do some more digging on that, the timing.
Great.
Anyways.
Yeah, thank you. Thank you for having me.
Yeah, I think in the setting, obviously with dementia care, we're seeing REM sleep behavior disorder in the setting of Lewy body disease. And so trying to think about medications which are lower risk. I do think with Lewy body disease, it makes a lot of sense to focus on melatonin and try to maximize melatonin before then potentially shifting to very low dose Klonopin, for example. But again, it's so much of it is how disruptive is the sleep. I mean, if somebody is, injuring themselves or others during the night due to the REM sleep behavior disorder, trying to, first you optimize the melatonin, and then you can keep the melatonin going when you then think about adding low dose clonazepam, but then also making sure that you're not missing untreated sleep apnea too.
Excellent. Any other last minute thoughts or questions? These are excellent discussion points, exactly why we do this. Going once, going
I mean,
twice.
I'll add one more thing, just since we're talking about REM behavioral sleep disturbance, which can be really dangerous, both for the person who's living with it and the care partner, and also trying to, as best one can, avoid the use of clonazepam. There's a couple other things that we can try in addition to melatonin, and so I'll just mention a couple. So maybe carbidopa-levodopa extended release. And there's some small, some people have had benefit there. You can try gabapentin. Gabapentin was mentioned. I mean, and see in an empiric trial. Kimmy, do you want to comment?
Yeah, no, it's so individual, and but I think it is so important to not miss the opportunity to lower the risks associated with REM sleep behaviors. Or I mean, just your sleep is disrupted. I mean, then there's the other parts about making sure that there's not a glass of water that could be shattered sitting by the bed, and thinking about the bedroom. Yeah, I'm sure we could, maybe that's the next topic for Dr. Fine for next year is REM sleep behavior disorder.
Yeah, I would say also, I think it would be helpful to talk about like, what's the history? How do you figure out that they've got it, right? Because I think it also just gets missed. And if you don't know the questions to ask and you don't know it sort of becomes part of the overall chaos but doesn't really get dialed in on. So.
Yeah, totally agree. It's particularly tricky for our population with PTSD and nightmares, and what's nightmares, what's REM behavior disorder. Excellent. Good potential topics. All right. So as we wrap up, and thank you all for hanging in until the very end here, here's just a reminder about the CME info if you are a UW affiliate. Our next session, just a reminder too, that we only have one session in November, second Friday of November, and one session in December, the second Friday of December. And our speaker will be Dr. Jennifer Gatchell. So stay tuned for the exact topic, but it promises to be outstanding. All right. With that, I will wish you all a good Friday and have a great weekend. And hopefully your Halloween costumes are all picked out.
Thanks, everyone.